Ja, meine Damen und Herren, guten Abend. Ich freue mich sehr, Sie heute herzlich willkommen zu heißen zu dem dritten Vortrag der Oberberg Online-Vortragsreihe. Heute am 5. Dezember zu dem Thema DBT for Children, the Dialectics of Addressing External and Internal Controlling Factors von Frau Professor Francesca Pereplecikova. Ich habe gerade so ein bisschen die Zahlen beobachtet und es kommen immer und immer wieder neue Teilnehmer dazu. Ich starte aber schon mit ein paar Folien, die wir immer zu Beginn zeigen, zu den organisatorischen Themen, die wir auch auf Deutsch hier haben. Und ich werde das auch kurz auf Deutsch mit Ihnen besprechen. Und dann switchen wir zu der englischen Sprache und wir kommen dann zu dem eigentlichen Thema. Deshalb starte ich jetzt schon, obwohl noch weitere Teilnehmer reinkommen, weil ich denke, viele Themen sind einfach, diese organisatorischen sind einfach Ihnen bekannt. So, unser Organisationsteam vor der Vortragsreihe online bei Oberberg sind Herr Professor Dr. Matthias Berger als Vorsitzender unseres Scientific Boards und meine chefärztlichen Kollegen, Herr Dr. Tobias Freier, Herr Dr. Andreas Walkordon und der leitende Psychologe und wissenschaftliche Leiter der Oberberg Parkklinik, Dr. Lars Hölzer. Ein paar technische Hinweise zu heutigem Abend. Bitte lassen Sie Ihre Mikrofone und Kameras deaktiviert während des gesamten Vortrags. Der Online-Vortrag wird aufgezeichnet und Ihre Beiträge sind in der Aufzeichnung aber nicht erkennbar. Fragen können Sie über die Funktion Frage und Antwort anonym stellen. Aktivieren Sie dazu das Häkchen anonym senden. Und die Auswahl an den Fragen wird im Anschluss an den Vortrag diskutiert. So werden wir auch unsere Diskussion gestalten. Bei den globalen technischen Problemen während des Online-Vortrags informieren wir Sie umgehend. Unser Host ist auch die ganze Zeit dabei und hilft bei dieser Art Problemen. Bei technischen Problemen wie Schwierigkeiten bei Ton- und Bildübertragung überprüfen Sie als erstes die Einstellungen an Ihrem Endgerät oder auch Ihre Internetverbindung. Nach dem Webinar freuen wir uns auf Ihre Teilnahme an unserer Evaluation. Die weiteren Informationen rund um unsere Vortragsreihe finden Sie auf unserer Homepage Oberberg Kliniken Online-Vortragsreihe. Da finden Sie Übersicht zu Terminen, Themen, Referenten, Moderatorinnen der Vortragsreihe. Da finden Sie auch die Registrierungslinks und auch die Mediathek mit aufgezeichneten Vorträgen, die Sie einfach noch danach in Ruhe angucken können. Bei Anwesenheit von 90% der Vortragszeit erhalten Sie 2 Punkte der Ärztekammer und die Teilnahmebescheinigung wird im Laufe der Woche an die bei Ihrer Registrierung verwendete E-Mail-Adresse gesendet. Wenn Sie Informationen zum Datenschutz brauchen, können Sie sie auch auf unserer Homepage abrufen. Noch ein kurzer sonstigen Hinweis. Die Vorträge ersetzen natürlich keine Therapie. Sollten Sie selbst ein Betroffener sein und sollten Sie Unterstützung benötigen, kontaktieren Sie uns gerne unter den Telefonnummern oder E-Mail-Adressen, die darunter aufgezeichnet sind. Und bei Lebensgefahr natürlich die Notfall- oder medizinische Notfalldienste. So, jetzt weise ich noch kurz hin auf unseren nächsten Vortrag in der Reihe. Das wird am 19. Dezember 2023 um die gleiche Uhrzeit sein. Zu dem Thema ist modulare Psychotherapie schon praxistauglich, wird Frau Professor Elisabeth Schramm aus der Freiburger Universität für uns referieren. Moderation wird Dr. Götz Berberich übernehmen, der ärztliche Direktor der Oberberg Klinik Windach. Und die weiteren Termine und Themen, wie auch Referenten, können Sie gerne eben auf unserer Homepage nachsehen. Und ja, wir laden einfach alle dazu herzlich ein. So, und jetzt übergehen wir schon zu unserem eigentlichen heutigen Vortrag und switchen zu Englisch. So I can introduce our referentin and briefly our topic, how we met together. I met Francesca Pereplechikova 5 years ago in Cologne during the year meeting of German DBT Association, Dachverband DBT. And we talked already at that time about my intention to establish an inpatient unit for younger children with emotional dysregulation in our clinic in Germany, in Mönchengladbach. Unfortunately, then came the years of pandemic, which slowed down all such developments and processes. But in September this year, we were able to expand our clinic, and we are just now in the process of creating our children unit based on the concept of DBT-C with Francesca's support. And that's the way how we fund together today. To Francesca, Professor Francesca Pereplechikova is certified in DBT by Marsha Linehan and Linehan board. She specialized in psychological services for children and adolescents with severe emotional and behavioral dysregulation, including suicidality and non-suicidal self-injury, severe verbal and physical aggression, treatment-resistant depressions, and generalized anxiety disorders. She deepened her expertise in dialectic behavioral therapy during her internship and postdoctoral training at the Yale University, and became a world pioneer in the development of the child-age adopted version of the DBT. As assistant professor in psychiatry at the Yale University of Medicine, she completed 2 randomized trials of DBT-C, and now she's an associate professor of psychiatry at the University of Massachusetts Medical School. But above all, she is a trainer of DBT-C, giving her courses and classes all around the world. So I'm very happy to introduce Francesca Pereplechikova and welcome her as our guest tonight. Only a few words more to the discussion part. The lecture itself will be held until about 7:30 p.m. And after that, we will have about 20-30 minutes for the discussion and your questions. And I would like to invite you to put your questions and topics to Professor Pereplechikova by writing them to this FA field in the Zoom. And you can write already during the lecture, so I can better sort it in advance. And I'd prefer if you write English, just to avoid the misunderstandings about the exact intention of the question, what can easily happen when translating spontaneously without consultation possibility. So, dear colleagues, I think it's so far, and I'm happy to reach the microphone to Francesca Pereplechikova now.
Thank you so much, Eva. Thank you so much for this introduction. I remember our meeting distinctly. It was a beautiful day in Cologne. We had such wonderful presentations from everybody. And you know what I also remember from that? That the whole wonderful celebration of people coming together and talking about the topics on DBT ended with beautiful celebration with great German beer and a lot of dancing. I remember
dancing,
that
tango dancing
specifically,
together,
right?
yes.
That was the only gathering that I have attended in DBT that included at the end beer and dancing. I think it's spectacular, and I think everybody should do that. So thank you so much for attending. Welcome to my talk. What I would like to say before I begin is this has been a long journey, and I would like to say thank you to all of the people who gave me this knowledge and helped me on my journey. And of course, Dr. Alan Kasdan, of course, Marsha Linehan, of course, Dr. Seth Axelrod, that contributed the most to my understanding of DBT and my ability to adapt it to pre-adolescent children. And I want to mention that my clients are my best therapists. My best teachers, because I learn most of what I'm going to present to you from my clients, from doing it with them. And right now, although I will have time to present to you empirical evidence on which the DBT-C, is resting, I can tell you that, the research that has been done has demonstrated that we can do DBT with children. And think about it. I presume most of you are DBT trained therapists, and most of you appreciating how hard it is to teach DBT to our clients, to apply DBT with our clients, and to actually give them the capacity to understand those concepts and be able to use them effectively. And translating it to children has been quite an ordeal given their developmental and cognitive level, but also thinking about it's not just one person that we are having in therapy. We have a child, and we have the entire village that it takes to raise that child, because we also need to include parents and grandparents and siblings and teachers and babysitters and aides, right? So it's a very different intervention because of that. And there are all other kind of things that have been included in the development of the model that I will try to present to you as succinctly as I can. And please forgive me if I run over the time. I know German punctuality, and I unfortunately don't necessarily can fully attest to my ability to be able to do this, because I do tend to talk a lot, and I am given a task to present a model that is very complex and has many moving parts in just 40 minutes. I'll try my best. And as we all know in DBT, function over form. So let's have no attachment to outcome and still try to maintain some sort of semblance of a form. Let's see how we're able to do that. All right, so can you see my screen? Can you see my slides?
Yes.
Excellent. Okay, so the topic of today's discussion is how DBT for pre-adolescent children has adapted the model, and which components had been added to actually address the needs of these children, given that we're not just working with the child, that we need to work with the system that is raising that child. And I would like to start with us, being on the same page with some of the metaphors and some of the things that I'm using to help the children understand what we're talking about. And as we all know, our kids are very good with computers. They understand computers. So the way that I'm discussing a lot of the time with children, what we're doing is I say, hey, our brain is a biological computer, which is true for all intended purposes, right? And every time we learn something, every time we make an interpretation about something, right, we write a program into our brain. And what we are here to do is we're here to learn how to reprogram ourselves on a level of consciousness, right? If you think about it, everything that we're doing is with skills training, with cognitive restructuring, with exposure. All of these are ways in which we're retraining our brain to function in a different way that is more adaptive. Pretty much, we are helping our children to rewrite in a way their software, right? Going from the programs that may be overlearned, such as I'm upset, I freak out, to I'm upset, I use a skill, right? So one of the things that we talk about with kids is these concepts. And I tell the child, hey, and the parent as well, hey, we come into this world already prepackaged. We don't come as a blank slate. We come with hardware, which includes your predispositions to physiological disorders, psychological disorders, your characteristics, your traits, your talents, your learning differences, right? And all other kind of instincts, for example, instinct of self-preservation, right? All of that is already in that package, in that hardware. And we call that hardware a David, a beautiful, wonderful piece of art that each and every one of us is, created by God, universe, nature, whatever you believe in. And now, at the moment of conception, that hardware, that David, starts to transact with the external environment, right? This transaction, the transactional model that DBT is talking about. And through that transaction, we're starting to write software, right? We're starting to learn. And now all of this software and all of this hardware is put in another metaphor called iceberg. Our consciousness, right, our psyche, right, consists of two parts. The tip of the iceberg is our conscious awareness, our thoughts, our memories, right? Below the waterline of this iceberg is the rest of its huge mass. It's much bigger, that contains our hardware, that contains our software. And this is basic psychology, most of our reactions, most of our responses, 90%, 90 of our reactions come from unconscious processes, right? I feel it, I do it situation. And only 10% is about conscious awareness. And what we are here to do is we are here to reprogram what we already have on a conscious awareness and also rise to the level of consciousness, what we have below the waterline, so we can say hi to it. We can get a freedom of choice from all of these programs, and we can start to override them. And if you ask me what I do as a clinical psychologist, one of my answers is I help people reprogram the way they think on a level of consciousness. Now, two sides to this transaction, the David and the environment. Let's talk about the target population, the David. Who are we working with in DBT-C? Specifically and primarily, we work with emotionally sensitive children. We call them supersensors. And this is how I explain it to kids and to the adults. Listen, supersensitivity means a little thing bugs me. Like somebody did not look at me right. Somebody did not say something correctly, right? And then this little thing can produce a huge tsunami of an emotional response. So I go from 0 to 100, and I go from 0 to 100 in a split moment, and then I have a slow return to baseline. And of course, because of these high level emotional reactions, I have corresponding behavioral dyscontrol, suicidality, self-harm behaviors, verbal aggression, physical aggression. Being a super sensor, being emotionally sensitive, has two sides, like anything in this world that's based on dialectic. We all know, right? Dialectic means two things are not the same. They're complementary. Day, night, man, woman, yin, yang, life, death, right? Everything has two sides based on the dialectic. And we just talked about the challenges of being a super sensor. However, it also has the advantages. Research shows us so many advantages of being a super sensor. They not only have negative emotions that they experience on a high level, but also positive emotions. When they get happy, they get really happy, all the way to becoming silly, which can cause its own problems, right? They are human x-rays. They can read other people really well, other people's emotions, right? We all know, for example, from our work with clients with borderline personality disorders, right? And they're all super sensors, most of them are super sensors, that they can read you as a page. Children are even worse than that, right? Meaning they have this emotional apparatus inside of them that they not only can experience their emotions on a different level, they can really sense another person's state. They may misinterpret what they are reading from a person, but that's a different story from being able to read, see the cues, understand the changes in a situation in a person's state. Also, they have increased empathy. They in the moments when they are calm between outbursts, they are very empathic. They're very caring. They're very understanding of other people. Also, emotional sensitivity is linked to the increasing creativity. Look, if you read the biographies of all the writers, the poets, the artists, they're all super sensors. However, being emotionally sensitive has a negative connotation of being a drama queen, right? Touchy, uptight, defensive, paranoid. That's why instead of using the term you are emotionally sensitive, we use a word supersensor by the analog of being super taster, right? A person who has a lot of taste bud in their palate, and therefore they can become a good food critic or a chef. However, it also has its own side, right? In which they cannot eat like a spicy food, or a little burger is not going to suffice, right? Similar is here. And when we talk about this as you are a super sensor, that decreases the risk of pathologizing. That is avoiding risk of invalidation. It also provides a dialectical view of the presenting issue, and a lot of the time gives the parents and the children a sense of relief. Oh, it's not that there's something wrong with me. It's not that there's something wrong with my brain. I just have this ability, this in a way a gift that I am just having hard time controlling. And the task is to give our children these emotion regulation muscles to be able to control the impact of this tsunami, to be able to benefit from all of the gifts of being emotionally sensitive. So this is how we present it. We say emotional sensitivity is a special ability that you need to learn how to better control. It's not a problem. Correct. I can't correct it anyway because you're born that way. It's in you, David. I can only give you the capacity to control it. And if I take away your emotional sensitivity, I also take away the talents, the gifts that come with it. I don't want to do it, right? And so you, being a super sensor, you need to learn super skills to control your emotional tsunamis, and you need support of super parents. One of the main tasks of DBT-C is to teach parents how to become super parents. We'll talk about it in a moment. Just everything is super in DBT. Super sensor, super skill, super parent. If emotional sensitivity is indeed associated with the development of emotional dysregulation, it does not resolve on its own. And without proper intervention, these children are at a higher risk to develop personality disorders, depressions, anxiety, alcohol use, substance use, suicidality, non-suicidal self-injury. All of that comes, unfortunately, as a way that a person trying to deal and cope with their emotional sensitivity, and they're developing all of these tools to help that unfortunately do help short term. Like you cut yourself, you decrease emotional arousal. Long term, you just pay for it. Now, let's talk about the other side of the spectrum, the environment. Emotional sensitivity and environment's inability to meet the needs of the child. So a child who's emotionally sensitive comes with high level of needs. An environment that can be really good enough parenting for other children. I have a lot of parents coming in with multiple children, and they say, to my other children are doing absolutely fine. It's just this one who is climbing walls. So it's not that the parents themselves are abusive or neglectful or don't know what they're doing. That can happen, but most of the time, that's not the point. Most of the time, they're very good, well-meaning, capable parents who can do good enough parenting. It's just good enough parenting is not good enough for the super sensor. And then this child with multiple needs is trying to impact on the environment, trying to satisfy those needs. Environment doesn't know what to do with it, and it's becoming dysregulated, impacting back on the child, dysregulating the child even more, who impacts on the environment, and so forth, all the way to inability to learn how to control your own emotion and becoming emotionally dysregulated. So, what I want to highlight, this is a different way in which transactional model in DBT-C is introduced, as it is introduced in DBT standard model, and I'm going to highlight a lot of deviations. In DBT standard model, emotional dysregulation is a product of emotional sensitivity plus invalidating environment. That's not so. That is not true. The transaction between emotional sensitivity and inability of the environment to meet the needs produces two products: emotional dysregulation and invalidating environment. It doesn't start that way. It develops through the inability to indeed meet the needs. As we said, most of the time, the clients who come my way have parents who are absolutely wonderful and capable, right? However, through this transaction, through inability to meet the needs, the environment can become invalidating, in which they just don't understand why the child is doing what they're doing, right? And it's very hard at a lot of the time to actually catch why the supersensor became dysregulated. Nothing obvious happened, right? And they start to invalidate, and then becomes an indiscriminate and pervasive. Good enough parenting is not good enough. Our supersensors need super parents. And this is the main goal of DBT-C. The child is the identified client. Parents are the main tools to address the needs of that child. And they need to become sufficiently equipped to do this, which means that they need to learn above and beyond of what type of parenting they need to do to address the need of this kid. And another metaphor, you see, we use a lot of metaphors in DBT-C, just like in DBT. Another metaphor here is that super parents are like firefighters. Firefighters don't start the fires themselves. What does it mean for parenting? Parents avoid modeling verbal and physical aggression themselves. All of this adult temper tantrum, screaming at your child. Don't do that. If you don't want your child to scream at you, don't scream at your kid. Avoid retaliation. Avoid harmful invalidation. On the other hand, so on one hand, firefighters don't start the fires. On the other hand, firefighters are not afraid of the fires. In parenting terms, it means don't accommodate. A lot of the time, our parents through this transaction start to be afraid of their kids. Validly so, absolutely. A lot of the time, supersensors suck all of the joy, all of the life of that family. Supersensors have this ability to enhance everything, right? To enhance joy, but also to enhance suffering. And then parents try to avoid any kind of outburst and start to tiptoe around the kid and start accommodating, which is absolutely terrible for many reasons. Instead, the synthesis: firefighters calmly and skillfully put down the fires and work on preventing new fires in future. And this is all of the parenting that we're teaching: how to validate, how to prompt and reinforce adaptive behaviors, working on own emotional regulation, right? Working on daily practice with their children. All of the things that we're doing with parents is indeed going into that synthesis in teaching him how to become the super parents that super sensors need. DBT-C has a great advantage over DBT standard model. In DBT standard model, all we are doing is trying to figure out what to do with the aftermath of the transaction with invalidating environment. There's nothing we can do about the past. In DBT-C, we can change the environment right now. And this is our main mechanism for the change for the child. And as I said, child is the patient, but parents are the main therapeutic tools. And when they come to me, that's exactly what I tell them. I, like a lawyer, my client is your child. You are not my clients. I am here to represent the needs of your kid, not yours. And you are the ones who are going to be my main tools to do this. So the only way I'm going to accept your family into treatment is if you tell me that you're going to do everything I tell you to do, even if it's counterintuitive. And we do a lot of work to prepare families into entering into DBT-C. We actually spend a lot of the time discussing with parents what will be involved and assessing their willingness and whether or not they are ready to actually enter into treatment. The main dialectic of DBT-C is, of course, incorporates the main dialectic of DBT standard model between acceptance and change, and it also adds its own specific dialectic, the dialectic between the synthesis, the balancing, working with external controlling factors and internal controlling factors. DBT standard model, and it's every way in Marsha's books, in a way that she's talking about, and it's even in the name. In the name, it says dialectical behavioral therapy. It is addressing issues on a level of response, on a level of the symptom. Suicidality, self-harm, screaming, yelling, drug use, alcohol use are not problems in themselves. They are ways to deal with problems. They're ways to cope. They become problems on their own accord, right? But they are not problems themselves. They're just symptoms. So external controlling factors is about my relationship with the external environment, right? And DBT-C adapted DBT model within how to indeed work on the level of a symptom and added the other side, how to work on a level of a problem. And level of a problem is internal controlling factors, my relationship with me. If I hate myself, of course, I'm going to self-harm as self-punishment, for example. If I don't feel safe with myself, if I cannot control the only thing I can in life, me, right? How can I indeed exercise any kind of adequate behavior outside, right? If I don't feel comfortable in my own skin, if I don't even belong with myself, how can I belong with other people, right? So in my view, DBT-C indeed made DBT dialectical. It's not just level of some symptom. It's now also the level of problem. It's not only my relationship with others. It's also my relationship with me. And this is the biggest part of the adaptation of DBT-C to the standard model of DBT. Two sides to our existence. Conditional side of the existence, unconditional side of the existence. Conditional side, external controlling factors, relationship with the external environment. The ups and downs of life. I win, I lose, people like me, people don't. I achieve, I failed. I gain mastery, I made a mistake. Up and down, up and down, up and down. By the principle of dialectic, what does the other side needs to look like to be complementary? If this is life, up and down, the other side needs to look like cut in stone, unmovable. Now, this is my relationship with me as that of an entity, neither good nor bad. I just am. When a human baby is born, is the human baby good, bad? No, it's just human. It's an entity like sun, moon, earth, squirrel, tree. What I do can be good or bad. But that's on the other side of the spectrum. And only when we are indeed able to maintain these two sides separately, we can achieve a synthesis of I just am, I'm always at peace with me. Peace with me means neither good nor bad. As soon as I say good, I can be bad. There's no peace. I am always at peace with me. I treat myself as an entity. I can actually connect to my self-love at will, and I teach how to do that. And I can win or lose. I can be happy or disappointed. Now we can have an end. Unfortunately, the information field in which we exist programs us to make everything one-sided, everything conditional, in which we're trying to achieve our good enoughness, right? Based on some sort of conditions, right? The merger between who I am and what I do has been created in our software. And then what happens is I succeed, I'm good. I fail, I'm bad. All day long. Now that is suffering, and even worse than that. Because of our negativity bias to the negative, right? Because negative may be unsafe. We automatically orient to that because of our sense of safety. We mostly see our mistakes. We mostly see things that we did or was done to us that we don't like. Therefore, all day long, it's not like I am good, I am bad, I'm good, I am bad. Not even that. I am bad, I am bad, I am bad, I am bad. What are you going to do about that? I can tell you what to do about that. Separate, learn how to indeed maintain the balance. And this is one of the main things that we teach in DBT-C. And this is the main dialectic between external and internal controlling factors, between conditional and unconditional side of the existence. So with that in mind, just going to show you how all of this operates, right, between the two sides. So we have external controlling factors, internal. External are events that elicit, reinforce, punish, extinguish, shape behaviors, right? Internal, this is where we're working on a level of me, my self-love, my safety, my sense of belonging. Now, this level of symptom, this is level of problem. This is relationship with the environment. This is relationship with self. Here we have standard DBT and DBT for adolescents. Here we have what is called core problem analysis. This is a model for assessment and implementation to target vulnerabilities in our three core senses of self-love, safety, and belonging that are affecting our relationship with ourselves. And all together, this is DBT for children. What is core problem analysis? As we said, it's a method to identify meanings that we assign to events. Events in themselves are neutral. I say, you're so stupid to 5 people, I'm going to have 5 different responses because 5 different interpretations. We are helping people identify their meanings. We're helping people identify the way that they interpret things. Because if you change the way you think, you change its products, our feelings and our actions, right? And a lot of the time, all of those interpretations, all of those meanings are not even in a conscious awareness below the waterline of our iceberg. So one of the ways in which we deal with that, we have a specific technique, assessment technique, which is a very cognitive technique, to get that out from the level of unconscious and not in awareness yet, to the level of awareness, so that we can say hi to it, moment of mindfulness, gain a freedom of choice from that program, and be able to override it with a different response. And once we identify which vulnerability is being affected, we can also have CPA specific interventions to address them. Just to give you another way of thinking about it, right? Like, for example, chain analysis, right? Chain analysis is identification of the external controlling factors. And this is recreating the sequence of events from already what was in conscious awareness. We're just trying to help the person restore from memory, conscious memory, what happened when and in which sequence, right? So chain analysis is what happened. CPA, why did it happen? You see, chain analysis is horizontal, CPA is vertical, going into meanings and interpretations so that we can change those. Why are we doing this? Because we're looking for functions. Every behavior is multifunctional. And what we want to do is we want to be as precise as we can so that we can match intervention by function of the behavior, not by behavior itself, right? So because otherwise, the response will continue to occur because only one function of the behavior was addressed. What about the rest of them, right? And we will not be able to satisfy that function with alternative methods. And especially if the client has no idea what the function is, and then we are increased risk of random solution generation. Try this, try that, have you tried this? And patient continues to fail, and which leads to burnout for the client and for the therapist, right? How to identify functions? We can ask a question. Sometimes we do know why we do what we do. We can conduct a chain analysis. We can start to identify patterns, test hypotheses, and conduct co-problem analysis. By the way, those of you who've been trained to think that DBT has nothing to do with unconscious, that's not true. Only these two are on level of the awareness. These are not. If you need to start to identify patterns and test hypotheses, it means that you are dealing with something that you don't know yet about. You need to identify it. You are dealing with not in awareness yet. Why again? This is so important. Just as I said, because all behaviors are multifunctional, I'm going to give you the example. Just tip of the iceberg in terms of the functions of non-suicidal self-injury. Coping, communication, peer group connection, attention, instrumental function, retaliation, self-punishment, fill the void, identity. Just the tip of the iceberg. If I am giving skills to a client who is self-harming, and the function of self-harm is to reduce emotional arousal. Excellent. I am matching intervention by function. Not a problem. It's going to work. But what if the function of my self-harm is to self-punish? Am I going to use skills? No. What if it's to retaliate against my parents? No. What if it's to connect to a peer group that also self-harms? No. That's why we match intervention by function, not by behavior. Now, let's talk about the ways that we're addressing external and internal controlling factors in DBT-C. I'm not going to spend that much time on addressing external controlling factors because you all know DBT standard model. I'm just going to give you bits and pieces here and try to concentrate the remaining of my time on discussing internal controlling factors. Now, just to make sure that we understand, DBT-C has a behavioral change model that consists of three parts. First, for you to change your response, you need to be aware. You need to catch that you're about to. Then you need to be also willing not to go there. All of that is necessary, but not sufficient. I can be really aware I'm about to scream at you. I can have a willingness not to do this because I know it's going to backfire. But if I don't know what to do instead, I'm still going to scream because that's the only way I know how to relieve my emotional arousal. So I also need to have a capability to do something otherwise. And how do I address it in DBT? Right? Willingness is the most important piece here. It's like a glue, holds everything together. I can be aware. I can know what to do instead. But if I don't give a damn, I'm not going to do any of that. So we spent a lot of time on willingness. And there are four main things that we're spending on. Intrinsic motivation, increasing extrinsic motivation, reciprocity between the parent and the child, and of course, understanding the functions of the behavior. All of that is feeding into the increased motivation and willingness. And specific interventions, mindfulness, skills, problem solving, cognitive restructuring, and the individual therapy and parent training component to address these. Now, main adaptations. The DBT principles and theoretical framework retain without modification. However, major additions are intensive parent training component and CPA. Also, modifications have been done to biosocial theory, target hierarchy, skills training, phone coaching, didactic on emotions, and the commitment, right? I cannot get into all of the details here. It will entail the entire training that I'll need to do with this. But I'm just giving you bits and pieces of information, unfortunately, all I can do right now in 40 minutes. I'm not going to spend that much time here. I just want to demonstrate to you how DBT skills have been translated from adult to child. Virtually all DBT standard model skills have been retained. They've just been relabeled and placed in a different part of the treatment. That's it. We cannot spend time on this, right? Okay. Now, we have the behavioral change needs of a kid. However, the same things are for the parent. And for us to figure out why the child's behavior is not changing. Is it about awareness? Is it about willingness? Is it about capability? We can't get to any of that if we don't have first this stable. We need to have this variable stable. Otherwise, we have too much error rate to understand what's going on with the kid. And therefore, we have an extended parenting component in which they need to learn how to model skills, how to reinforce adaptive behaviors, how to ignore dysfunctional behaviors, how to suppress, dangerous behaviors, how to validate the child. And the topic, the key message to the parents is your child's behavior is irrelevant, capital letters, until you are able to effectively support progress. We always start with parents. Parents are the most important ones, and you can see it in the treatment target hierarchy that has been extended from 4 to 10. Remember, we are addressing a village, not just one person. 3 main categories. We are working on decreasing the risk of psychopathology in adolescence and adulthood. Long-term goal of that is our main, a priority. Whatever we're doing is for that task. We cannot do this without establishing a parent-child relationship conducive to changing the transaction. And only tier 3 is about targeting child symptoms. That's why the parents are here, but that is the least of our concerns. What is more important for us to even get there is these 10 things. So I'm not going to concentrate on each and every one of them. The only thing that I want to highlight here is look at that. After life-threatening behavior of a child and therapy destroying, not therapy interfering, therapy destroying behavior of the child, then the rest is first, parent, 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 parent. At number 7 and 8, we're talking about child screaming and yelling and all of that stuff, right? Not that important. These are all of the things that we're teaching the parents in their parent training component. And DBT-C, external controlling factors, addressing external controlling factors, is based on 3 main mechanisms. Number 1, we need to get the parents emotionally regulated. Most of the time when they come to you, they're not. We need for them to establish the foundation for change. We need for them to learn validation and practice validation. We have a huge time spent on validation. And the third one is skills practice. You see, not use, skills practice. How many times did that child programmed and coded and recoded the same maladaptive program of I'm upset, I freak out? 10 years of daily coding and recoding. That's a very strong program. Are we there to expect that after we teach a skill, the child is all of a sudden going to do it when they're upset? Absolutely not. No person in their right mind will want to use a skill when they need to use a skill. And we're asking that of a dysregulated, emotionally sensitive child who is immature, who is 8? Absolutely not. So what we need to do is we need to practice in between. One of the main things that I'm asking parents to do is on a daily basis, practice using skills in hypothetical situations. Let's pretend what I'm going to do, and then you practice it with the child in role play, and then you reinforce it with points and praise and rewards. Practice, practice, practice. Now, the other side to that, addressing internal controlling factors. Again, I will not be able to spend that much time on it, but I just want to give you main highlights of what we're working with. And what we're working here is helping people decrease vulnerabilities in their 3 core senses: sense of self-love, safety, and belonging. What are those? Sense of self-love is not self-love. Self-love is an instinct of self-preservation. You're born with it. It's pre-programmed to increase your chances of survival. Sense of self-love is ability to connect to your self-love consistently and reliably at will. meaning treating yourself as you are. Remember this one? I just am. An ability to do that is indeed solidifying that stance, being able to connect to yourself and see yourself and maintain that stance of I just am. Unfortunately, information field in which we exist programmed us to merge who I am with what I do, and therefore we created an illusion of needing to satisfy some environmental criteria, requirements, some conditions. I can only be good enough for me if I am tall enough, thin enough, smart enough, pretty enough, successful enough, and only then I can love myself, which is completely insane because we're trying to accomplish something that is unconditional with satisfying conditions. It's insane, but we all do this, right? And one of the things that we're teaching is indeed go away from that insanity and how to connect to your self-love without going through all of these steps that I'm going to do it anyway, because you cannot connect to your self-love by satisfying conditions. And then if you learn how to do this, if you drop this need to continuously prove to yourself that you're good enough, you can do something amazing. You can indeed learn about your David, who you are, what your actual talents are. You can love your David as you are, and you can live your David, self-actualize your David. And much more easily accept inability to meet the requirements and standards of the external environment, right? Now we can have a non-attachment to outcome. It's wonderful to talk about don't have attachment to outcome as we're doing DBT, right? It's a wonderful concept, but how can we indeed do this? If my relationship with me is based on the outcome, right? I succeed, I'm good, I fail, I'm bad. How can I not be attached to it? So the only way to give a capacity to do this is indeed help the person separate and put these two sides where they belong. I just am, and I can succeed or fail, be happy, or feel disappointed, right? Only then we can have it. And see, I continuously say capacity, capacity, capacity. Teaching, skills, giving psychoeducation, all of this information is wonderful. Great, we start there. Necessary, not sufficient. You also need to gain the capacity to do this. And one of the things that we're doing by conducting CPA and all of this work with our children and parents is indeed feeding into the capacity to apply all of the knowledge that they're gaining in therapy. Now, of course, parental love for the child provides the foundation for the child being able to experience their self-love, right? And if a child is, if a parents are, stuck in shoes, how my child should be, then, there's a lot of invalidation because they're trying to force the child to become, something in their own image and shape. No, we as parents are not there to create a David out of the already existing David. David arrived. You gave birth to it. Your job as a parent is see the David in the child, love the David in the child, and make sure the child sees the David in the child, loves the David in the child, and self-actualizes that David. And of course, pervasive, indiscriminate, invalidation will interfere with child's ability to connect to their self-love. If my parents don't love me as I am, how can I? Now, sense of safety. Second one, sense of safety is an ability. It's not safety. We cannot assure safety. I'm sitting here pretty safe, and a big meteor can crash on my house, and in 2 seconds, I'm a bunch of molecules. Can I assure my safety? Absolutely not. And in this day and age, in this world in which we exist, we control nothing. We control nothing. I don't control my capacity to reach the bathroom. I don't. As I'm getting up to go to the bathroom, a big meteor crashes on my house, and I'm just a bunch of molecules. What did I control? Nothing. Nature allows me to reach the bathroom over and over again, but that's as far as it goes. How many variables need to happen just like that for any outcome, including reaching the bathroom? Infinite number, apparently on a level of galaxy. And I'm just one variable. Very important one. Because if I did not decide, I will never get there. But just one. That's why outcomes are never on us. Process, yes, but never outcomes. And we know this. Below the waterline of our iceberg, we know all of this. We know we don't control other people. We know we don't control life and circumstances. We can't even control ourselves. No, we can't. Stop thinking about a white elephant. You haven't been thinking before, but now can you stop? If you could control yourself, your thoughts, you would be able to do it. You would say, okay, I don't want to think about it anymore, and it would stop. Now that's control. No, but what you can do is directly influence by using skill such as la, 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 in your head, right, to push away the thought of an elephant. But that's not control. That's an influence, a direct influence, right? So in this life that we control nothing, that's pretty scary, right? And unpredictable. And we still need to have some sense of safety to get out and do things, right? Otherwise, we will sit in our hole, in our cave, and starve to death. What does it consist of? Number one, ability to, and when I say self-control, I use this term loosely, right? It's just a colloquial term. By that, I mean directly influence me. Ability to control the only thing I can, directly influence the only thing I can, me, what I do, what I feel, what I think, my biology. Plus, accumulate resources, knowledge, connections sufficient enough to handle challenges and have a realistic appraisal of danger, right? And all of that starts to develop in a secure environment that's predictable, consistent, and continuously offers protection and support to the child. And continues to develop when the child acquires enough control over own responses and starts to accumulate knowledge of, yeah, I can successfully solve problems, right? And the environment in which we don't have this consistency and protection that continuously to invalidate your child and accommodate dysfunctional behaviors, the child's ability to trust self, others, in the world goes down, and they don't learn how to regulate. Third one, sense of belonging. We are animals that are, or creatures, whatever you want, that can only survive in groups. That's it. We cannot survive by ourselves, right? We're not predators, right? Look at me. I don't have claws and fangs. I don't have like musculature of a predator. I don't even have a tail. I have nothing. Right? Drop me in the middle of Serengeti, I'll be dead. Drop me with the group of people. Yes, now I have a much higher level, probability of survival. And we are all control freaks, sense of safety. We need to be in control. First word of a child is mama. Second, papa. Third one is usually what? No, right? This little, kid who just barely learned how to walk and talk is already trying to exercise control. Yes, we are all control freaks, whichever degree, some more, some less. And even our David is dialectical. Everything is dialectical, including our programming. On one hand, nature made sure that we want to exercise control in this life to feel safer. But she needed to counterbalance it because otherwise we would not be able to coexist with other people. And it counterbalanced it with inborn benevolence. Sense of belonging is benevolence, inborn benevolence, inborn need to affiliate, inborn need to congregate, inborn need to actually provide care and support to the sick, to the young, to the old, right? Support each other, be careful with each other, be compassionate towards each other, right? All of that is part of the sense of belonging, right? Which is welcomed and accepted into the group, and as well as making new, as well as my connection to my ancestry, right? Sense of belonging, of course, starts to develop within the family. through the positive transactions with the caregivers and pervasive invalidation, in which a child is criticized, judged, retaliated against. Messages are being sent: we don't like you, you're a monster, we don't even know how you were born to our family, sometimes verbatim. What kind of a sense of belonging child can have, right, if he's not even welcome and accepted in his own family? What do we do with that? First, we help people understand what their programs are. And each program has a primary function, has secondary functions and primary functions. I cannot get into this. However, the primary function of every response, adaptive or maladaptive, is to decrease vulnerability in all of those three core senses. It just maladaptive responses decrease it short-term, increase long-term, and adaptive responses can do the opposite. They can increase short-term and decrease long-term. Let me give you an example for maladaptive. Self-harm. Now, I'm going to give you a skeleton of the core problem analysis. How do we get those programs out? It's much more complicated. This is just a skeleton. You self-harm. Why did you do this? So we ask questions why, right? Questions on the function. What does it do for you to self-harm? When I self-harm, everybody comes running. Why do you need that? Because then I get attention, support, and care. Why do you need that? Because then I feel lovable, and I feel protected, and I'm not alone anymore. Self-love, safety, belonging. Look at this. This is a program that the client did not know before. A client did not know before that they're self-harming to feel protected. No. Or that if they self-harm, other people will come running and they will feel lovable and therefore they're good enough to love themselves. None of that is conscious. But look at this, conscious or not conscious, this is a program, biological computer, right? All programs, by the virtue of being a program, are logical and rational. That's the validity. Makes sense. What the person is saying makes total sense, right? So rational and logical, valid, given the causes, given the learning, right? Two sides to everything. It's rational and insane at the same time. For me to feel protected, I need to harm myself. For me to love myself, I need to harm myself. That's insane. So you see, short-term gain, long-term loss. Adaptive behavior do the flip. Now, this is about going through the door of pain or suffering, right? We all understand that pain, meaning what? Challenges that come my way, right? We don't like challenges. Why are they painful? Sense of safety. Why? Because it's something that's uncertain. We don't know what's going to happen. Will I be okay? Will I solve the challenge? Will I not? Will I fail? Uncertainty. And this is why it's pain. Suffering, and this is a very normal human existence experience. We all get challenges all the time. We can't avoid pain, and we need pain. Why? Because that's the only way we'll learn and gain more mastery, right? That's it. Suffering is not a natural part of life. Suffering is self-inflicted. How? By avoiding pain, by running away from pain, right? We all know this from standard model DBT. Suffering is pain plus not accepting pain, right? So imagine it's two doors, door of suffering, door of pain. Whenever challenge comes in, we go through this door of pain, uncertainty. And that's why vulnerabilities in these three core senses start to increase. Sense of safety. Oh my God, what if I'll make a mistake? Sense of self-love. What if I will not good enough? Sense of belonging. What if everybody will think that I'm a loser and not want to be with me, right? Going through this door. And then we arrive on the other side. So short-term, increase vulnerability, long-term, decrease, because on the other side are all the other doors. Door of self-actualization, door of self-control, door of forming your own groups, door of this happiness, joy, all the doors are there. on the other side. So one more time. Primary functions of all responses, and they're primary and secondary. Secondary functions, for example, coping, decrease emotional arousal. It's a secondary function. Why is it a secondary function? I can still ask a question, why? Why did you even get emotionally dysregulated, right? Retaliation, that's a secondary function. You know, why did you even need to retaliate? Primary function is where I can no longer ask a question why. I cannot ask a person, why do you need to be safe? Or why do you need to love yourself? It's like asking a question, why do you need to breathe? We arrived at the core. There's nowhere else to go. We are at hardware. I can only ask a question, why, about software, what you yourself made up in your own mind, your own meanings, your own interpretations. Here I'm at hardware. That's why I can no longer ask a question why. So one more time. Primary functions of all responses, adaptive, maladaptive, is to decrease vulnerabilities in these three core senses. It just maladaptive, reduce vulnerabilities short-term, increase long-term. Adaptive, do the flip. They are increasing short-term sometimes, decrease long-term. And once we understand what's being vulnerable, which kind of sense is being affected, CPA is providing specific intervention of how indeed to address and work with decreasing these vulnerabilities in a healthy manner. And just one more slide, all of this together, one more time, conditional, unconditional, relationship with others, relationship with self. Ups and downs of life, I'm an entity. This is win some, lose some, stable, unwavering. Here, all range of the emotions, they're all triggered. Self-love is not triggered. Self-love exists in you at all time. It's an instinct of self-preservation. Self-love is a gift, not an accomplishment. We treat it as an accomplishment, but that's one of the insanity, right? Sense of safety is completely conditional. You actually need to accumulate resources, connections, and your own ability to control yourself. Sense of belonging, both. It is unconditional in the sense of the ancestry into which you were born, and conditional in terms of the groups and connections and family that you form yourself during life. And what do we do with that? If it's just conditional side of the existence, my relationship with the external environment, we teach adaptive coping skills, we do contingency management, the usual, right? If it's unconditional, we still need the adaptive coping skills, plus we do CPA. And thank you so much for the attention. I knew it, I ran over, and it is what it is, no attachment to outcome.
Thank you very much, Francesca, for this absolutely exciting lecture, but above all, for this tender, loving attitude towards the super sensitive children and overstrained parents too. I have a few questions from the audience, and
Can you, because I will definitely forget. Can I introduce something? You can learn more about what I am talking about if you go on my website. I have all kind of information there. It's called childdbt.com. As simple as that. And you can even subscribe to my newsletter, monthly newsletter, for continuing to get more information on all kind of developments in the world of DBT-C. Also, I started my YouTube channel. Can you imagine that? Yes, I started, such a pain. I started my own YouTube channel to continue to talk about this and to continue to rehash some old ideas, new ideas. And I also have trainings for parents and for clinicians. And we'll talk about more about trainings for clinicians, but I just want to introduce training for parents. I have training called Super Parenting 101 that I offer to the world. It's 24 weeks. And remember how I said I'm teaching parents to be therapists. There are actually the training is pretty much the same as that for the clinician. It just condensed and simplified, right? External controlling factors, internal controlling factors, right? And I offer that training 3 times per week to accommodate different time zone for 24 weeks from April to September of every year. If you have parents who can speak English and may be interested, more than welcome to send them my way. And all of that information is on a website for parents, for clinicians. And we'll talk a little bit more about training for clinicians at the end if you're interested in becoming a DBT-C clinician. Yes, Eva, sorry.
Thank you. Thank you very much for this opportunity. I think it's really great because one of the questions was how to manage that in the all-day practicing. I understand the question is how you teach the parents, the children with this program.
Yeah, very good question. So there are two models, research model, clinical model. Research model is once a week, 90 minutes, parent and child coming in, about like 30 minutes with the child separately, 20 minutes with a parent separately, and 40 minutes with parent and a child doing skills training, right? That's the research model. Oh my goodness. I never recommend anybody doing a research model unless you absolutely have to. For example, child is highly suicidal and you cannot wait to introduce the child into treatment. I always recommend doing clinical model. Clinical model is you do assessment with the child and the parent to identify whether or not the child's condition and clinical picture indeed something that you can help address within DBT-C. And after that, you don't even see the kid. You only see parents for as long as necessary. Sometimes it's 2 months. Sometimes the longest ever without me being able to introduce a kid into treatment was a year and a half. These parents were a complete mess, right? So, and what do I accomplish with that? Number one, the most important variable for change is parents, not the child, as you can imagine, right? The child is embedded into the system. So I want parents to learn everything that they need to learn in terms of what to do with the kid. I also want for them to gain the capacity to do all of this. They need to do work on themselves. Also, if they're two parents, I need for them to become a team. Most of the time, they're not a team. Because when the child enters therapy and we need for the child to change, nobody likes change. Change introduces uncertainty, sense of safety, right? Even positive change, nobody likes. What is statistically speaking, what do people say about what is the most stressful event of their life? The most stressful? Getting married, positive change, right? So, when child gets introduced into therapy, what we're going to do is we're going to destroy the present dynamic that nobody likes, but everybody feel comfortable with, only in the sense of I know what's going to happen, I can predict, and therefore I know what I'm going to say, what they're going to reply, right? And when we destroy those dynamics in therapy, child is not going to like it at all. It's going to be very hard. So therefore we need to have parents who know what to do and can withstand that challenge. Otherwise, it's very hard. Otherwise, we stand a chance of actually making it worse. Imagine ignoring. If child has never been ignored in the past, or sometimes yes, sometimes not, and all of a sudden the parent is starting to ignore. And the kid is like, what's happening? Maybe I need to do more of it. Maybe I need to do worse than that. Maybe now I need to scratch the grand piano. And we are entering into the extinction burst, right? So now parents that never ignored, all of a sudden are ignoring for 20 minutes. Fantastic, wonderful, except for at minute 21, they no longer can do it because they don't have the capacity. And they gave in and reinforced that behavior with whatever attention. What did we just do? We made it worse. We reinforced at escalation. We don't want to do that at all, right? So that's why I always hesitate to take a child and a parent at the same time, because there's a higher chance of making it worse. I only take parents and then I do whatever I need to do with them to prepare. And then I can dangle child entering into therapy as a carrot. When they ask me, so when can we bring the child in? I say, I don't know. It's on you, not on me. Clean up your act, do what I tell you to do, and then I'll be able to bring the child in. You know what? So there's so many functions to that. And once the child is in, the therapy looks like 1 hour with the child, 1 hour with the parent every single week. And then as the therapy is progressing and parents really know what to do, what I do is I decrease the number of times I see parents from once a week to twice a month, and then once a month, depending how well they're doing. And then once I can see that the parents know what to do, have a capacity to do it, and develop enough consistency to do it, I say, bye-bye, I don't need to see you anymore, even if the kid is not fully there yet, because I am not the main therapist for the kid. Parents are. And I want to give it into the main therapist's hands who actually now know what to do. I don't need to see this child. I can take another person in, right? Now, this works really good, unless the child, of course, is like highly suicidal, whatever, then you do research model. And good luck with that. I got a lot of gray hair out of that, right? But sometimes the severity of the child's, self-harm, whatever, may not be as risky. And then what we do is we do in between, we do safety sessions. We teach the child some skills and whatever, and that's it. And maybe we could do one or two or three safety sessions and still continue to work primarily with parents, right? And then when parents are ready, get the kid into treatment. And to tell you the truth, we accept families into therapy, even if child is refusing. That happens, not a problem. If parents are refusing, I'm not accepting treatment, regardless of how much the child wants. I need one parent who is capable, who is willing. Another parent is a luxury. A child on top of it who is willing is even luxury on top of luxury. One parent who knows, who is willing, who is capable, who is ready.
And how do you get the parents to the mindset they are willing to do what you say they should do? Or
well, I
did you
have
have
all kind of
also
tricks. I have
did
all
you
kind
had
of
also
tricks.
parents who you are not able to work with, and how you deal with
Well,
it?
if parents are not willing or capable of working, I don't accept them into treatment. If I accept them into treatment, chances are it's going to fail. And if it fails, then you just burned out yourself. You burned them out. You did not get anything out of it. And next time when they're ready, they will not go back to therapy because now they have a negative, memory of that. Also, you just took a place of somebody else's who indeed can succeed and use your help. Just because family comes your way, just because family needs you and child desperately needs you, does not mean that they're automatically in therapy. Absolutely not. Just like with standard model DBT, we don't take all clients who need us. We need to have a commitment. We need to have a client who is actually willing to do it. Same as here. It's just here we don't accept parents or families if child is committing and parents are not. Right? We accept families when parents make an informed commitment, even if the child is not willing. We don't care about child's willingness. They don't even have to be in therapy, right?
So
Now, how do we prepare? The question was how we prepare.
mhm.
I have all kind of tricks. For example, I have this list of things, associated factors with being, emotionally sensitive. And when a family is calling me, if I hear just enough information to know, oh, that's my super sensor, I stop the family and I say, let me tell you about your child. And then I go through the list of associated factors, and usually 90 to 80 to 90% hit. And parents like, how did you know that? This is very important because if I knew about their kid before they had to tell me, maybe I know something. Maybe I am an expert. Maybe I can help them. So they're already coming into treatment with me, just assessment piece, right? Already with the mindset that I know what I'm talking about, I'm an expert, right? And then when they come in and I do an assessment of the child's symptoms, I do simultaneous assessment of the parental readiness. I tell them, oh, these are the symptoms. That's how we're going to address it. This is what I'll be asking you to do. Are you willing to do it? Even if it's counterintuitive, for example, ignoring. It would be very counterintuitive for you to hear from me when your child is telling you, go to hell, bastard, and is verbally abusive to you, asking you to do the 3 monkeys. I don't see you. I don't hear you. I don't talk to you. This is counterintuitive. This is not what our parents did to us, right? That's not the modeling we sustain from our parents. This is not what society is saying. You're supposed to jump in and say, how dare you? You should stop doing it. This is disrespect, right? No, that's not what you're going to do. Will you be willing to do this? And very importantly, throughout the treatment, I'm going to give you pieces of the puzzle of what to do. And you will not know what the entire picture looks like until you connect enough of them. So most of the treatment, I'll be asking you to do something that will be counterintuitive, mood inconsistent. You're not going to want to do it. And you will not even understand why. And I will be asking you to act as if you understand and agree and own that. Are you willing to do this? So, and this is the preparation that we do with parents at each and every step. By the time we get to commitment, they know what they're getting yourself into. And then before they commit, right, I ask them one last question. I say, and the answer to that question determines whether I accept you into treatment, right? Because acceptance into treatment, commitment is not only from the client, it's also from you. You are committing to this client, right? So you have to give the agreement. I asked them one last question. When I ask you to jump, what will be your response? And the only one that I take is how high. That's what they have to say. And then I'm okay, you're in, we can do the work. And that's exactly how I train my therapists in what to do, how to do, to indeed be able to gain a better ability to work with the families. Because think about it, once you accept them into treatment, inadvertently, you're going to run after them, right? Run after them. So save yourself some mileage, make them run after you, convince you that they are going to will be willing to do whatever it takes and jump as high as you say, so that once you accept them into treatment, you're not going to work as hard.
Thank you. I have many interesting questions, I must say. One question is, according to parents, how do you manage it that the parents don't feel like only the instruments?
Or why not? They should feel like an instrument. Why? What's the problem with them feeling like they're an instruments? That's exactly what I tell them. You are my instruments. That's
Okay.
what it is. What's the
Okay.
problem with that? I don't
Okay.
see.
Mhm. Uh, one question to the frames. What is the youngest child you have experience with?
Well, DBT-C model as a model with, the external controlling factors, internal controlling factors, this can be applied to anybody, even before you give birth to your child and you want to learn how to be the parent that your child may need, right? All the way to your 80 and your child is 60, you still know how to be validating to your child and how to support your child and how to be the protector that you need to be. And our parents are own protectors, only protectors, right? Regardless of our age. Anyway, so I'm so sorry, I forgot the question.
What's the youngest child you have
Age.
experience with?
Now, the research model is 7 to 13. That's the research. That's what it was validated for, right?
Mm-hmm.
I use this model with adolescents. It doesn't really matter. We still need to do CPA. We still need to involve parents above and beyond the degree that usually a DBT for adolescent model is calling for. I use it with young adult clients, right? It's just the older they are, the less involvement of the parent. The younger they are, the more involvement of the parent. The youngest client I have is a 2-year-old. Of course, most of this is with parents, but you can teach 2-year-olds skills. My own children were my guinea pigs for developing the model of the adaptation. My son was 2 when I taught him his first DBT skill. I don't know why I chose that one, but I chose the easiest DBT skill to teach a 2-year-old, called radical acceptance. what is the radical acceptance for 2-year-old? You need to teach them to say, oh well, and
Mm-hmm.
then couple it with reinforcing them dropping the issue. They cannot talk about it anymore. They cannot say anything anymore. They need to stop the temper tantrum. They say, oh, well, drop the issue, reinforcement. You couple it, and at some point it becomes an automatic response. My son is 18. I say, Danny, all well, he's all well. So still works. An overlearn the program works. So you can indeed do a lot of this. You just need to be creative in how to teach, how you teach, right? Like CPA. The youngest child I did CPA with, getting those programs out through this analysis, was 5.5. The youngest child that I taught how to sit with self-love was 4.5. So you can do it with a whole range of clients. And of course, most of that is with parents anyway. Of course, with kids, but still they're adults, right? They can do
Actually,
CPA,
with
they can
parents,
learn all
yes.
of this, right? That's not an issue.
We have still only 2 minutes, and I have also a couple of questions about the adopting of the DBTA or DBT to DBT-C. And I think the focus is how to learn DBT-C
Well,
here. And
right. So
maybe you can
let me give
tell
you
something about the courses you
absolutely. So
you
adapting
give.
DBT standard model and DBTA with incorporating DBT-C. The only thing that I do different when I work with adults or adolescents, I use the same model. I use DBT-C model. The only thing that I do different is I use DBT for adolescent handouts for skills or Marshall Linehan's handouts and model for adults. That's it. That's the only difference. But in terms of the structure, in terms of the content, it's very, very similar. Of course, less parenting component as they're older, more parenting component as they're younger, but the model and the principles and the strategies are the same. I have a course that Eva and I are trying to put together to offer DBT-C workshop to German clinicians. And you're more than welcome to attend. The course will be offered in December of next year. Course is two-part. Part one, 3 full days, which is going to be in online format, meaning that online format, we need to divide it into 6 half days to make it easier, plus to accommodate the time difference between you and me, right? So it's going to be 6 half days back to back, Saturday, Sunday, Monday of 1 week, and next Saturday, Sunday, 1 day. Part one, then 6 external controlling factors, 6 months in between for you to start adopt all of this, use the learning, try to, incorporate it into your practice. And then you see me once a month for consultation for 1 hour in teams. They're going to be constructed out of the participants. You don't have to come in teams. You can come by yourself. And then after that, 1 month, 6 1 hour supervisions during those 6 months, and then you come back for part two. Same thing, 6 half days, internal controlling factors. And this course in Germany is going to be offered in December 2024. 2020, yeah, 2025. Yeah.
2024. Yeah. Thank you very much. I think it will be
Thank you for inviting me.
Great opportunity to get deeper knowledge and auch also practice in the DBT-C and learn it from you. So for everybody who still have questions, please ask for these terms, and we will mail to you uh, uh, more details to the courses Francesca will give in December 2024. And now I just thank you very, very much, Francesca, for this great lecture. Very interesting
Thank
and
you for inviting me. It was a pleasure.
Exciting for us. And thank you for the audience, for everybody, for every participants for taking part in it. And I
thank you for being here.
Thank you very much, and have a nice evening for
and
everybody.
I hope to see some of you for the DBT for Children workshop in December.